Welcome, and thank you for joining us for a conversation on Alzheimer's disease, where we are and where we're headed with Dr. Laurie Ryan. My name is Mary Mel, and I'm the Executive Director at Kensington Park Senior Living, a Kensington senior living community offering independent living, assisted living, and 3 levels of memory care located in the heart of Kensington, Maryland. Kensington Senior Living has 7 unique communities, 4 on the East Coast in Virginia, Maryland, and New York, as well as 3 in California. Our promise is to love and care for your family as we do our own. We are committed to keeping you current with the latest advances in care, management, and treatment of conditions that affect seniors and their families, which brings us here today. If you're new to the Zoom platform, this presentation is in webinar format. This means your cameras and microphones will remain off and muted throughout the presentation. We will be answering questions at the end through the Q&A. I am thrilled to introduce Dr. Laurie Ryan, Chief of the Clinical Interventions and Diagnostics Branch in the Division of Neuroscience at the National Institute of Aging, which is part of the NIH. Laurie has been with NIH since 2005 and oversees the development and coordination and implementation of the division's clinical, therapeutic, and diagnostics research programs and infrastructure. She also directs the Alzheimer's disease and related dementias pharmacological clinical trials research portfolio. But Laurie is very special to our Kensington family, as her father, John, lived here for over 10 years. We were so honored to care for him and love spending time with Laurie during her regular visits. She will always be part of our forever family. Welcome, Laurie.
Well, thank you very much, Mary. Hope everyone can see me and hear me. Yeah, it is absolutely my pleasure to come and give this presentation. As Mary said, I'm still a family member of Kensington Park, and I'm happy to be able to give you all updates for 2023, where we're at and where we're headed, because I think it's a very exciting time. And why don't we go ahead and, Mary, bring up the slides? Oops.
Well, thank you for joining us. Yeah. We appreciate you.
Absolutely. Thank you. Okay, so I wanted to start out with a little bit of an overview of Alzheimer's disease and what it is. So it's the most common cause of dementia in people aged 65 and over, and that's really late onset dementia. And I will talk a little bit more about what that means compared to early onset. It's a general term, dementia, for memory loss and impairment and other cognitive abilities that interfere with daily life. And there are multiple causes for dementia. Alzheimer's is as I said, the most common in older people. It's progressive, and there's gradual decline in your activities of daily living, behavior and personality, cognitive memory and thinking. Okay, next slide. This graphic just shows you the other types of dementias in addition to Alzheimer's. So I'm not going to go into this, but I wanted you to have the information. Alzheimer's, as I said, is the most common, but there's also frontotemporal dementia, there's Lewy body dementia, and there's vascular dementia, and even what's not on this graphic, but sometimes there's mixed dementia with different types of pathology in the brain. Next slide. Okay, next slide, please. I think I'm one ahead of you guys. There we go. Now we're good. Okay, so when we're talking about Alzheimer's, it really is, as I said, a disease of decline. So there's losses in memory that's subtle at first, then followed by greater impairment in thinking and other cognitive abilities, behavior that progresses over time. When we look at a brain, we see structural changes. So if we do a brain scan, over time, neurons die and the brain actually shrinks. At the microscopic level, when we look at autopsy, for example, there are hallmark changes that we see, amyloid plaques and tau tangles. Next slide, please. And this is just a better schematic of what the tau tangles and amyloid plaques look like in the brain. And so the tau is in blue and the amyloid is in brown. And so when we talk about amyloid, these plaques, these clumps form when beta amyloid protein pieces kind of clump together. But we think the most damaging form of beta amyloid may actually be groups of fewer pieces, smaller ones, smaller groupings that actually clump together to form the plaques. And the plaques may be actually the brain's way of trying to protect itself from the toxic amyloid. What happens is it blocks the nerve cells or the neurons from being able to signal to each other. also can affect the immune system and triggers inflammation in the brain. And as far as tau goes, an abnormal form of tau builds up inside the neuron. And this abnormal form of tau clings together to other normal tau proteins, forming these tau tangles that lead to cell damage and death. Next slide, please. And there are a number of risk factors for Alzheimer's disease. Age is the leading risk factor for late onset. Of course, there are genetics involved, as well as sex, females, and we're going to talk more about this in a little bit. Cardiovascular disease puts you at risk, metabolic diseases like diabetes, poor sleep, lack of physical activity, poor diet, like the typical Western diet, education, having low educational attainment, not having cognitive stimulation, and a number of other environmental factors, including things like pollution. Next slide, please. And when we talk about the genetics of Alzheimer's, for late onset, there's really one gene, the apolipoprotein E4. That's the strongest genetic risk. And you can have 0, 1, or 2 copies of this gene. And having 2 copies puts you at the highest risk. But it's really important to note that having ApoE4 is not sufficient to cause Alzheimer's disease. So ApoE4 risk actually varies with race, ancestry, as well as sex. It's greater risk in women. There are numerous other actually AD risk genes that have been identified, but these have a much smaller effect than the ApoE4. And we talk about early onset Alzheimer's disease under the age of 65. That is fairly rare, less than 10%. It usually affects people between the ages of 30 and 60, and it usually runs in families. And in some cases, it's again very rare, but less than like 3%, it's caused by an actual mutation in one of 3 genes. Next slide, please. But in addition to genetics, there are also lifestyle factors that can impact your risk for dementia. So you can't control your genes, but you certainly can control many of your lifestyle choices. So things like controlling high blood pressure, as we said, cardiovascular disease is a risk. We've known from a big study called Sprint Mind that people that lowered their blood pressure to 120, this was a very intensive blood pressure lowering, actually had reduced risk of developing what we call mild cognitive decline. And I'm going to talk about the Alzheimer's disease continuum in just a minute. So that's a risk factor for going on to develop dementia, this MCI as we call it, that lowering blood pressure intensely actually did have a big impact. Also sleeping, sleep is terribly important. We know that for a lot of diseases. Healthy diet, as I said, having poor diet, the Western diet, unlike the Mediterranean style diets that are more fruits and vegetables and healthy oils and fish, those things can actually also help. Keeping physically active, as I said, being sedentary is not good, but not just physically active, but also keeping cognitively active. And finally, staying connected with family and friends. So social engagement is also very important. These are things that we have found that by looking at observational studies, that people that don't have good connections, don't have with their family and friends, or not physically active, those things can actually increase risk for developing dementia. While again, we don't know yet for certain if these will prevent the disease on their own, they will help you with your healthy aging. It's also good for your heart. Of course, what is good for the heart is also good for the brain. So these, in addition to hopefully we're going to be talking about the treatments that we have, can really be combinations of what we're going to need to do to prevent and to treat dementia. Okay, as I mentioned, Alzheimer's disease is really a continuum. It actually starts in what we call a preclinical phase, where we see brain changes, and these can be a decade or more before symptoms, but you don't have symptoms yet. Mild cognitive impairment due to AD is where there are very mild symptoms that may or may not yet interfere with your activities of daily living. And then when you actually have dementia, when there are symptoms, they are starting to interfere with activities of daily living that progress, to moderate and to severe. Next slide, please. This is just another graphic showing the continuum of Alzheimer's. It's looking at cognitive function over years. As you can see, as we move forward, you get more cognitive dysfunction, thinking and memory issues as you go through the years with Alzheimer's. Next slide, please. Of course, I want to talk a little bit about where we are in terms of the numbers of people who have Alzheimer's. And this actually comes from the 2022 Alzheimer's Association Facts and Figures. They put one of these out every year. And in 2022, we have the number of people in the US, this is the US population, estimated to have Alzheimer's was about 6.5 million. And the estimated number of people actually comes from something called the Chicago Health and Aging Project, or CHAP. It's a population study looking at chronic health conditions, not just Alzheimer's disease. Next slide, please. And a recent NIH-funded study estimated the number of Americans living with Alzheimer's will double by 2050. So that's going to be about 12.7 million. And in 2021, the total national cost of caring for people with Alzheimer's and other dementias was projected to reach $355 billion. Next slide, please. And Alzheimer's actually also varies by race and ethnicity. As you can see here, it's just showing rates across different age groups for different racial and ethnic groups. So from non-Hispanic, white, African-American, Asian and Pacific Islander, Hispanic, and then finally American Indian and Alaska Native. And as can be seen, as we move up, everyone's risk does increase, but people of color have a higher burden of disease than non-Hispanic white individuals. And this higher risk of incidence is maybe due in somewhat to some genetic factors, but that does not explain everything. What we think is happening here is that the disparities in access to health care, in education, structural racism, all those factors come into play in increasing the likelihood of dementia in people of color. Next slide, please. As I mentioned a little bit earlier, sex is also a variable when it comes to Alzheimer's disease, with more women than men having AD and dementia. Almost 2/3 of Americans are with AD are women, and of the people greater than 65 in the US, 3.8 million are women. So this represents about 12% of women and 9% of men in the US. And we don't think this is just linked to longer life expectancy in women. There is some evidence that women show more rapid cognitive decline and, excuse me, I'm moving my notes along here a little bit too fast, show more rapid cognitive decline and neurodegeneration than men, despite having similar levels of beta amyloid tau and other AD pathology. Some of the differences may be hormonally based, and there's research going on now to really understand what these sex differences are. Next slide, please. And this is just showing the differences across different racial and ethnic groups with gender. And you can see that the prevalence in women is higher across all groups. Next slide, please. I want to shift gears now and really talk about how we diagnose, monitor disease progression, and look at treatment response in the clinical trials where we're evaluating therapies. And that really is, we're going to talk about AD biomarkers. And so what is a biomarker? Well, it's a biological marker. I'm sorry, next slide. Just making sure. Okay, thank you. Next slide. You've got the right slide. Don't go too far ahead. I'm jumping ahead of myself here. A biological marker of substance, a measure that indicates a biological state. So, and these biomarker changes may exist before clinical symptoms of disease arise. And we talked about that a little bit. We have MRI scans of the brain, and this is more for late stage of development, where you could actually see the brain shrinking. We have PET scans now that can actually use radioactive tracers that are injected and it can actually light up or attach to the amyloid proteins and the tau proteins that I mentioned earlier in the brain. So we can actually see in a living brain where amyloid is being deposited in the brain, what areas are affected, how much. Same thing with tau. There's also cerebral spinal fluid tests. So people do a spinal tap, and you can look for abnormal levels of amyloid and tau. And finally, blood tests. And there's recent progress happening here. And I'll talk a little bit about where we are in terms of the progress with being able to screen people in their doctor's office, not yet, but hopefully in the not too distant future, where we can screen for amyloid and tau, which we know puts you at risk for developing Alzheimer's. So I'm going to talk a little bit more about those. Next slide, please. Great. And so this is just a schematic, a drawing from a paper that shows healthy older adults and individuals with Alzheimer's, looking at structural MRI, which we can see brain atrophy, FDG PET, which I didn't mention, but really shows metabolism, how well the brain is using its fuel, which is glucose. Amyloid PET, again, which shows the deposition of amyloid in different areas of the brain, and same thing with tau. And there's some other newer ones that are not yet FDA approved, but looking at neuroinflammation and something called synaptic density, which is the synapses or the connections between the nerve cells in the brain. So is what this graphic also shows, you can see at the bottom is clinical to research. So the things with the higher level on clinical are what can be used now. So we have structural MRI, we have FDA approved amyloid and PET. We do not have yet approved scans for the neuroinflammation or synaptic density, but they are, being used in clinical research right now, although they're not available clinically. Next slide, please. In addition to the imaging biomarkers, as I said, we have fluid, CSF, and blood-based biomarkers. The exciting thing is in 2022, the FDA has actually approved two biomarkers or two types of tests for biomarkers of amyloid and tau. That just happened earlier this year. The blood biomarkers, as I said, are not yet approved by FDA. Several of them have been given what we call breakthrough designation, and that's where they're put on the fast track to be approved. So hopefully we'll see approved blood-based biomarkers soon for the clinic. They are being used now to screen individuals for clinical trials and other clinical research. Next slide, please. And this graphic, what I wanted to just demonstrate here is that the changes that we see in biomarker don't all happen at once, and they happen differently. So typically the yellow line, the amyloid changes first. You can pick that up, then followed by tau, then changes in brain structure, and then the clinical symptoms, memory, thinking, activities of daily living come into play. So that's why the scans are so important, and the blood test will be too, because we can actually, again, identify people at risk way before symptoms are showing up, where we might be able to have a better impact with our treatments. Okay, next slide, please. And the other thing that's important to note that amyloid and tau are key players, sure, in Alzheimer's, but it's a complex syndrome, not just a single entity, with multiple pathways leading to dementia. Next slide. We're really looking at a precision medicine approach here, which is not just, of course, for Alzheimer's, it's for other diseases too. Cancer, all the other diseases are really moving in this direction. The right disease, pathway, target, therapeutic agent, and dose for the right patient at the right stage of disease. Okay, next slide. And this is the meat of the presentation, so I hopefully will be good to go till the end. I want to talk about where the treatments are for treating and or preventing AD. Next slide, please. Just a quick overview of how we find out if treatments work. Well, we use clinical trials, which is a research study to evaluate the effects of experimental interventions, or tests for diagnostic agents are also tested in clinical trials, PET imaging tracers, for example. And clinical trials are really voluntary research studies conducted in people and designed to answer specific questions about the safety or effectiveness of drugs, vaccines, or other therapies or tests, or new ways of using existing treatments. And the schematic on the right-hand side is of the clinical trial phases. And so you can see we have things that are preclinical, that's in animals, and then we have phase 1, 2, and 3, where we start off really looking just at safety and tolerability of an intervention. And then ultimately, when they get to phase 2, starting to look to see if it's effective, and then finally, if it's effective and safe in a large number of individuals. Okay, next slide. Currently, there are several treatments that have full approval by the FDA, and they're for Alzheimer's, and they are symptomatic treatments. And what does that mean? That they provide temporary symptom improvement for some patients, but they do not continue to work as the disease gets more severe. And those ones are donepezil or Aricept, rivastigmine, like Exelon or galantamine, or razidine, and memantine or Namenda. Okay, next slide. Recently, we've had 2 treatments that have received something called accelerated approval. And these have been disease-modifying therapies, anti-amyloid therapies, they're immunotherapies. And what that is, they're really passive immunization. So where we are actually giving the antibodies against amyloid, in this case, through IV infusion, and that gets to the brain. Whereas if you have active vaccination, which people are very familiar with COVID, that's where you actually rev up the body's immune system to create its own antibodies. So this is a little bit different, although active vaccines are also being studied. These are passive vaccines. And what does accelerated approval mean? Well, it means that they were approved based on what we call the surrogate marker. So in this case, the surrogate marker is the removal of amyloid plaques based on PET scans, not necessarily on whether or not they had improvement in clinical symptoms. Although lecanemab was recently, and I'm going to talk about these results, did show improvement in clinical symptoms, but that was not part of the approval process. So right now, with accelerated approval, these drugs are not paid for by Medicare, but CMS, Centers for Medicare and Medicaid, are actually going to reevaluate this if drugs get full approval. So right now, it's accelerated approval for these drugs, but certainly for lecanemab, and we'll talk about this a little bit in just a little bit, they are actually moving forward to asking for full approval based on their latest study. And I'm going to talk about that next. The next slide. So lecanemab, or the brand under the brand name now Leqembi, is as I said, an anti-amyloid immunotherapy. It works on a particular form of amyloid. They're called protofibrils, and they seem to be particularly toxic to brain cells or neurons. And the drug attaches to the protofibrils and prevents them from clustering together to form those amyloid plaques. And the large phase 3 study in almost 1,800 individuals called Clarity AD, these results were just presented in December of 2022 at a big meeting called the Clinical Trials for Alzheimer's meeting, CTAD. It was in early AD, which included individuals with MCI and mild AD, that had evidence of amyloid plaque on PET scans. This trial was better than many in that it had greater inclusion of ethnic and racial groups in the US, resulting in approximately 25% of the total US enrollment, including Hispanic and African American persons living with early AD. This has not been the case. I don't have time to talk as much as I'd like to, but diversity in clinical trials has been a huge issue for the US, not just for Alzheimer's disease. And this trial actually did a better job than many. The results showed cognitive clinical decline was slowed. Remember, these are people with symptoms by 27%, starting at around 6 months of treatment, and they did show decreased brain amyloid. Next slide. So this is more than you'll need to see, but the two lines are showing the differences between lecanemab in the yellow and placebo group who got the non-treatment, they got the placebo injection, so they don't get any actual active medication in that case, were different over time for all of the measures that were utilized. Now, its 27% change is a modest improvement. It might mean months or years of, staying in a milder state of Alzheimer's disease. So this is really just the beginning. But it is not too strong a statement to say that it's a watershed moment for the field where we've actually been able to impact the disease process, in this case, amyloid plaque in the brain, and have a clinical benefit. So we hope this is just, the beginning of many, but it certainly is a huge leap forward, not just a step forward for the field of Alzheimer's and related dementias. Next slide. The important thing to note is that there are also a number of side effects with lecanemab, Leqembi. So one of the things that we've noticed with all of the anti-amyloid immunotherapies, Aduhelm and the others, is that we see something called amyloid-related imaging abnormalities. We either see brain swelling, edema, or brain hemorrhage, bleeding. Generally speaking, these are not symptoms, are not associated with that. They're just detected when MRI scans are done. Some people do have symptoms: headaches, vomiting, confusion, gait disturbance. The risk for what we call ARIA correlates with the dose of the anti-amyloid drug, as well as if you have 2 copies of the ApoE4 allele, which is also known to put people at risk for something called cerebral amyloid angiopathy, or CAA, and that actually is where there's amyloid in the vasculature that puts people at risk for bleeding, for brain bleeding, as well as the concurrent use of what we call anticoagulants or blood thinners. During the trial, the most common reported side effects were infusion-related reactions, headache, and ARIA. Deaths did occur in 6 participants in the treatment group and 7 in the placebo. And none of the deaths in the actual trial, the double-blind trial, were considered to be related to lecanemab or occurred in the presence of ARIA. However, participants in the main trial, the double-blind trial, double-blind meaning that the participants and the doctors didn't know who was on drug or not, those folks have been extended, everyone being put on drug. There have been 3 deaths reported with brain swelling and bleeding that may well be linked to the treatment. And in these cases, it seemed to be there was the presence of CAA in or anticoagulant use. So this really highlights use. It really highlights the importance of a careful and considered prescribing of lecanemab and also monitoring. And I'm going to talk about that on the next slide. Next slide, please. Oh, sorry. Next, can you go back one? Yes, thank you. So people with, I'm sorry, it's hopping around on my end. Could you go to the next slide, which says lecanemab use? Apologies. Okay, there we go. People with early, again, it's for people with early AD, MCI, and mild AD, confirmed presence of beta amyloid. That was who was treated in the trial. There are no safety or effectiveness data on initiating treatment either earlier or later in the disease. They have to have monitoring for ARIA, we just talked about on MRI, and the drug is administered via IV every 2 weeks, and that means going to a hospital or into an infusion therapy center. Current cost for the drug are $26,500 per year. Again, as noted, because it's under accelerated approval, Medicare does not pay for its use. It will pay for the use if you're part of a clinical trial, but it is not paid for right now. That may change if there is full approval of the drug, and I'm certain that Medicare will then be reevaluating on payment. For right now, they've made a decision actually for any anti-amyloid immunotherapy. They're not going to pay for it with accelerated approval, only what we call with evidence determination, which means as part of a trial. But like I said, that may change. Okay, next slide. Okay, and importantly, the other thing to note is that was all those trials were in people who already have Alzheimer's, dementia, or MCI. And right now, it's also being studied, lecanemab, in cognitively healthy older adults with a preclinical AD. So these are prevention studies. One I'm going to mention is the AHEAD study that's co-funded by the NIH as well as by industry and nonprofit foundations. There's another trial looking at cognitively healthy, mildly symptomatic adults with early onset autosomal dominant Alzheimer's. And I'm not going to spend a lot of time on that one, but that's the Diane TU Tau Next Generation trial. And that one's also supported by NIA as well as industry and nonprofits. Next slide. So the AHEAD study is really 2 studies that are in parallel, A3 and A45, testing whether lecanemab can slow or stop the earliest brain changes due to Alzheimer's in people with a higher risk of developing the disease later in life because they have amyloid currently, although they are asymptomatic. So it's going to enroll 1,400 people, ages 55 to 80, 216 weeks of treatment. And again, for the A5 trial, people will be preclinical but have elevated amyloid on PET scan. And with the A3 trial, they're going to have an intermediate level of amyloid, so not as high of a level, to see if those make a difference, the level of amyloid when you come into a trial and how much amyloid is removed. So this is really, it's currently recruiting. It's the first enrolling participants as young as 55 who are at risk for AD. It's using a blood test to rule out people not likely to be eligible. So you'll get a blood screen first, and if you have amyloid on the blood test, then you'll go have a PET scan, which is required for entry into the trial. So again, targeting the earliest changes in the brain. It's using an approach that actually tailors the dose level to the study participants' brain amyloid levels. So there'll be differences between the A3 and A45 trials. And it's the first really to test an investigational treatment in this population that's already shown to lower brain amyloid and slow disease progression in people with early AD. Next slide. And from this slide, this is just showing where the sites are for the AHEAD study in the US. So there's 75 locations in the US and Canada. If you go to the AHEAD study site, aheadstudy.org, you can actually look to see where the sites are. And there are many probably in certainly on the East Coast and the West Coast, less so, which is typical, unfortunately, in the middle of the country, but we do have good coverage out here. Next slide. It's worth noting that there are other anti-amyloid immunotherapies that are in clinical testing that look promising, and we hope are promising. Next slide. So one is the anti-amyloid treatment in asymptomatic AD, or the A4 trial. This trial is fully enrolled and has just completed at the end of 2022. There is an open label extension that's still going on, but the results from the main study, the top line results, are due out this first quarter of 2023. So we're waiting to hear what's going to happen with the A4 study. This has been supported by the NIA as well as industry and foundations. So this has 1,300 participants looking at, again, cognition in individuals who started out with healthy cognition, so they don't have any signs, at least on testing, of MCI or dementia, but who are at risk based on, again, having higher levels of amyloid on PET scan. These folks were ages 65 to 85. So it's very exciting. We should be hearing, not too far in the future, what the results are from this study. Next slide, please. There's another drug called donanemab. That's also an anti-amyloid immunotherapy from Eli Lilly. It's in 3 different trials, Trailblazer 2, 3, and 4. 2 of these, or actually all of them, are phase 3 trials, 2 in early AD, and 1 that's in preclinical AD. So hopefully for some of these, like the Trailblazer 2, that's due to complete later this year, we should have results shortly as well. So there may be another anti-amyloid therapy depending on what the outcome of that study that the FDA will be considering for accelerated approval. Okay, next slide. This slide really just depicts where we are with the number of, this is drugs only in trials right now. And you can see the graphic is actually, one is from the Alzheimer's Association and one is from a paper. The important part here is when you look at the one on the right, the different colors represent different therapeutic targets. So amyloid, tau, inflammation, vasculature, oxidative stress, things we talked about a little bit. So there's many therapeutics under development, and it's a very exciting time. More are still in the earlier stages than in late, because unfortunately that's the way it works. We have many trials that start out early, but they may not be safe or effective. And so not as many get to the phase 3, the large testing that we need for drugs to actually be approved. Next slide. The NIA supports many clinical trials as well. And currently, this was as of September of 2022, this particular slide. There were 65 trials, 57 of which were early stage trials. And you can see, again, looking at everything from amyloid to inflammation to vasculature, just what you saw on that other graphic. And we have a number of trials that are in late stage again. So these are the phase we call phase 2B or 3. So those are kind of later stage all the way up to full phase 3 trials. Next slide. And there are 3, one I've already talked about and 2 I am going to talk about. One is the AHEAD study, the A3 and A4-5 trials, as well as HOPE for MCI and the MAP study. Next slide. The HOPE for MCI trial is using a drug that has already been approved for use in epilepsy. It's called levetiracetam. And AGB-101 is simply an extended release formulation of that drug. And this trial is testing the safety and efficacy of AGB-101 to slow disease progression in 164 individuals who have MCI due to AD, ages 55 to 85. So this study just completed at the end of 2022, similar to the A4, and we're expecting top-line results in the first quarter of 2023. And what's exciting about drugs like AGB-101, these are repurposed drugs that have already been found to be effective for other indications, is that they generally tend to be cheaper, more widely accessible because they've already been through the rigorous testing. So we're very excited, to see what happens with this drug if it works in individuals with MCI. Okay, next slide. Another repurposed drug, this time metformin, which is glucophage XR. So it's a long-acting form of glucophage, which is an FDA-approved medication for diabetes. The trial is metformin and Alzheimer's dementia prevention, or MAP study. And it's, again, testing safety and effectiveness of metformin, this time in 370 individuals with MCI, again, ages 55 to 90. And this trial is currently recruiting. You can see the 10 sites on the right-hand side of the slide that are recruiting for the MAP trial. This trial is expected to complete in 2026. Next slide. So while I've highlighted a number of the exciting things coming out from drug trials, it would be remiss to not talk about the non-pharmacological interventions, many of which are lifestyle interventions that are being supported primarily through the NIA and NIH. These are not, they're not drugs that money is going to be made from, as in a pharmaceutical industry. So NIH is the main player in non-pharmacological interventions, clinical trials. And you can see we have exercise, cognitive training, diets and supplements, stress reduction, music therapy, even devices, and that's what the neurostimulation is. Can you stimulate the brain transcranial, so it's outside of the skull, and have an impact on cognitive functioning. Next slide. And one of the non-pharmacological trials that recently finished and reported out, but I think it's incredibly important to talk about, is the EXERT trial. This was in 296 sedentary older adults with MCI, ages 65 to 89. It was 12 months of aerobic exercise versus 12 months of stretching and balance. It was done in conjunction with YMCA. So individuals went to their YMCA and worked with a trainer, both the stretching group and the aerobic group. And it tested really whether supervised exercise can slow cognitive decline, brain atrophy, and delay onset of Alzheimer's, full-on dementia in those with MCI. Next slide. So the results were presented this summer, and participants with MCI in both the aerobic exercise group and the stretching group did not show cognitive decline. Again, this is individuals with MCI that you expect to show decline over time. And in fact, a comparison was done with older adults in a different study, an observational study, the Alzheimer's Disease Neuroimaging Initiative, who did not have the EXERT interventions, but showed significant cognitive decline over 12 months. So looking at the similar group from ADNI, as we call the study, where we saw decline, we did not see decline in either group in the EXERT trial. So this was unexpected because the expectation was that the aerobic exercise would be better. But this suggests that regular physical activity, even modest or low exertion activity, such as stretching, may have a beneficial effect. And certainly this will have to be teased apart more because this is not what anyone was expecting. The EXERT study was the longest ever phase 3 study in older adults with MCI. It was conducted during the height of COVID, but even with lockdowns and everything, 80% of study participants completed their exercise regime and completed the study. And it's really a tribute to the commitment and flexibility of the study participants and the study team. So next slide. I want to highlight another trial that's actually primarily funded by the Alzheimer's Association, which is the US Pointer study. And this is looking to reduce cognitive decline in individuals who are at risk, about 2,000 individuals, ages 60 to 79, by looking at modifying lifestyle interventions, one on self-guided program and one that's more intense structured program. And this is currently recruiting, although should be wrapping up with their recruitment in the not too distant future. Next slide. And the US Pointer, there are a number of add-on studies that are funded by the NIA, trying to really see what happens to the brain in terms of imaging, looking at the effect on vascular disease in the brain, looking at sleep, as well as impact on the microbiome when you change lifestyle. So the microbiome that's coming up more and more now is what we eat, and the bacteria that are in our gut can have an impact on disease, health and disease, as well as maybe response to interventions. So it's an incredibly exciting new area that's being looked at. And all these studies are part of the US Pointer study, which is one of the largest in the US, looking at modifying lifestyle factors. Again, things like diet, exercise, blood pressure, diabetes in the US. It was based on a large Finnish study called the FINGERS trial, which saw some improvement in individuals, slowing of decline in individuals at risk for going on to develop cognitive decline and dementia. So we're now taking this study to the US. And I should note there's actually a worldwide FINGERS, as it's being called, which is being done in multiple countries globally. Next slide. So to wrap up, the future is really going to be likely combination or cocktail approach, where we're going to have a combination or multimodal therapy to reduce the impact of AD. And that combination is going to be based on an individual's specific risk factors and will likely be combination of medications as well as lifestyle. I would liken it to what we do with cardiovascular disease, right? People have different dietary, they have diet, they have exercise, as well as, maybe a lipid drug to lower cholesterol. So, and for Alzheimer's, we might see a cocktail of therapies. You have something for targeting amyloid, tau, and neuroinflammation, as well as cardiovascular risk. Next slide. I want to come back to this precision medicine approach because that's exactly what we're talking about. Combinations of therapies, but with the particular combination, based on precision medicine. So it's targeting the right disease pathways, using the right agents at the right dose for you as an individual, as opposed to one size fits all. Next slide. And I didn't have time to add this in, but I want to note that in addition to the treatments and preventions, both drug and non-drug, we also are looking at the NIA on interventions for dementia care and the caregiver. So that's also credibly important. That could be a whole talk all by itself. But I want to note that that is also very, very important and critical aspect of the research that the NIA does. Next slide. And finally, all of these studies could not be done without the participation of volunteers. It's critical that we have individuals across all walks of life, different stages of disease, people without disease, volunteering to participate, because without volunteers, we will not find the answers and find the cures and treatments for Alzheimer's, as well as many, many other diseases. The NIA has a whole host of information about clinical trials and clinical research, whether or not it's right for you, how to find out about it. Next slide. And this is alzheimers.gov. This is the US government's Alzheimer's site. It's run by the NIA. We have a clinical trial finder on there. You can also look at the Alzheimer's Association websites. They also have a trial finder. It's called Trial Match. There are many ways to see about participating in clinical research. And we really hope that people do, because like as I said, it's critically important, and we will not find answers without all of us volunteering to participate in clinical research. And I think my last slide is coming up. If you'll go to that, and those are my dogs, Jenna and Shadow. I just have to put them on there because they're cute. And I want to thank you, and apologies for the meltdown on the internet, but I think we got through it, and hopefully there's still time for questions. All right, the first one is, can the new biomarker test be requested and used as a tool to measure the extent of decline? The new biomarker tests, the ones particularly for the plasma or the blood test, those are really right now just being used to will be used to screen people. That more testing needs to be done, more research needs to be done about how well they will track disease progression over time. We certainly know we can track progression with the PET scans, but more research is needed for the blood tests to see if they're also going to be good at tracking individuals over time. They will most definitely be good at screening individuals and then going on for further evaluation, much like cholesterol is used now in cardiovascular disease, where it's, puts you at risk. It doesn't mean you're about to have a heart attack because you have high cholesterol, but we know you're at risk and we want to start you on treatments. And that's really the hope for like the blood markers. But we do need more testing to see how they do with tracking disease progression. Next question from Kathleen Michaels is, how early can MRI detect preclinical or early Alzheimer's? What are the early markers? So when we're talking about MRI, that's really later in the disease process, when we start to see changes in what we call brain volume, because as we see neurons die, we do see shrinkage on the brain and the volume of the brain decreases. So that's not the earliest changes. You can see that as when we're talking MCI and you're moving forward. But when we're talking preclinical, that's why the amyloid and tau markers, as they are the first changes to happen, amyloid in particular. That's why those are the early markers. And that's true. As you said, nothing's been shown to reverse or stop the progression. There is something, the lecanemab has been shown to slow progression, correct? Nothing has been shown to stop or reverse it at this point. What we saw with lecanemab was a modest slowing of expected decline, but that is correct. Nothing has been shown to stop it or reverse it at this point.
I think
Okay.
that's all the questions we have. We can close out with Ryan.
Absolutely, and I will make the slides available to everyone if they want them. So feel free to, for Kensington Park, can share them, and I'm happy to answer questions, and if people can send them my way for, Kensington Park knows how to get in touch with me. I'm happy to answer questions. Oh, I see one more. For those with Alzheimer's, how often should one get a brain scan? So right now, brain scans are really used, the PET scans are used for differential diagnosis. They're not used, continuously. They are used right now to track progression in terms of treatment trials. So right now, you wouldn't get more than, say, if you had a question of whether or not it was Alzheimer's or something else, you'd get a brain scan. You would continue to get those brain scans, generally speaking, once you've had a diagnosis, but that may change over time. But currently they're used for diagnosing. Which currently, what's used to track progression? Well, the measures of cognitive change, which are the memory tests, those are used to track progression, and those are good. They are also looking in terms, again, research. We look at progression. You can look at that through the PET scans, and hopefully some of these other biomarkers that are the fluid-based biomarkers, the less invasive biomarkers, will be used as we move forward. But right now, the PET scans are the furthest along. What other than amyloid and tau? So yes, so as we talked about, there's multiple factors that lead to Alzheimer's, one of which, of course, is having cardiovascular disease put at risk, diabetes. Those are all put people at risk. Inflammation, which can come from things like cardiovascular disease. Neuroinflammation is clearly involved in the process. So amyloid and tau are just part of it. And there are many therapies now. I could have had a slide just looking at where we are with trying to treat neuroinflammation in the brain. So that's one of the key areas. The other thing, the Hope for MCI trial mentioned, but what that's based on, why it's an epilepsy drug, is that we seem to have, certainly in people with MCI due to AD, it looks like there's what we call overexcitability, hyperexcitability in the brain. So it's almost like it's not having seizures, but having subclinical seizures, if you will. It's a way to think about it. There's overactivity that leads to beta amyloid, leads to developing plaques and tangles. And so that's why the Hope for MCI trial is actually using levetiracetam, which is an anti-epileptic drug. Someone asked me to talk about, where are we? Hold on. Can I talk about my dad's dementia? Sure. So my father was older when he got diagnosed. He was mid 80s. So he had a later onset, and he had about a 10-year course of fairly slow progression up until 2017, when he had a small stroke, which really pushed him over the edge in terms of the dementia. He went from, being needing assistance, but not needing full dementia care to needing full dementia care. So it was a long road with him. We were very fortunate that he was at Kensington Park, because he had absolutely outstanding care. The team there is, as they said, just like taking care of their loved ones, because he was very well cared for. And we were very fortunate we could afford to have him there. And I know not everyone has that luxury, but it was a long road with him. And he passed away at the beginning of 2020. So right before COVID came into play in terms of, locking down everything. So I felt fortunate that I at least got to see him up to the end. So yeah, I think it went pretty well until, he had the strokes and his dementia got worse. And he also developed, I didn't have even a chance to talk about, the neuropsychiatric symptoms. He had significant agitation and psychosis, which was the most challenging, I think, of all the symptoms that he had. And the team at Kensington were wonderful in handling him, because that was a very, very stressful time. Okay. Let's see. Let me try to get to some of the other questions. You guys keep me on track here. Yeah, could I say a bit more about exercise? Sure. So exercise, we've known from observational studies and from animal studies that we can see impact on brain health in with exercise. And it has been shown, as you can see from the EXERT trial, maybe just physical activity, not necessarily full-on aerobics, can seem to slow. People did not show decline who had MCI, which is pretty remarkable. So there are more studies ongoing to really look at whether or not it can do more in terms of a prevention space. Is it, if you give it to have individuals engage in exercise, can they really slow or put off developing dementia? It's not likely that exercise alone or anything alone, just like diet alone, is going to prevent disease, but it's certainly going to give us, if you think about it as a healthier functioning, so that when brain changes do occur, it may take longer for them to show up and may not be as severe. So it will be always, I think, part of the treatment regime for people should be including things like diet and exercise for Alzheimer's. So one of the other questions here is, so are most of the approved treatments showing any success in slowing? So the epilepsy drug I mentioned, that trial has not ended, so we'll have results on that very soon. But the drugs that have been approved, there are ones that treat symptoms. That's the things like donepezil. That will help with symptoms, but willing to help for a short period of time in some people. The other two drugs that got the accelerated approval, the one, Aduhelm, was a bit more controversial because one of the studies was positive and one was negative, that the FDA went ahead and gave accelerated approval on. But the lecanemab study, the phase 3 results are very compelling. Again, a modest improvement. This is not a cure, but showing that you can slow decline. So I think the lecanemab study is really a watershed moment, and we hope we can build on that. And we also think that going earlier will also be helpful, at least for amyloid. I should note that there are other therapies that may be able to help regenerate, neurons. And so that rescue is probably a better word. So we're not giving up on people that have disease. It's not just amyloid focused, but hopefully there may be drugs that you can come in even if you have MCI or dementia and actually show a reversal. So people are looking for that as well. They're just earlier on in the clinical trial process. So how often can you get? Yep. Sure. Yes. So I'm trying to see where is one more. Yeah. So how often can one get a PET scan? So PET scans are, there is exposure to radiation. So there are rules, and I don't have that off the top of my fingers. I know in terms of studies that we do, clinical trials, oftentimes there may be a year between PET scans, 6 months, something like that. They are not done daily though, because you do get a dose of radiation for PET scans. But right now they're used for diagnostic purposes, as I said. And when you get repeated scans is usually as part of clinical trials. So I think we'll have to stop there, but sorry, I'm glad all the questions started popping up. Sorry, I couldn't get to all of them. So.
Laurie, thanks so much for joining us this evening. And we have great caregiver events coming up. So please tune in. And thanks again, Dr. Ryan. We really appreciate it.
You're welcome. Again, sorry for the technical difficulties on my end.
No problem. We're glad you made it back.
Yeah. All right. Thanks. Bye-bye.
Bye-bye.